Recording in progress.
안녕하십니까? 대한루푸스 연구회에서 루푸스 건강 수칙을 말씀드리고자 본 동영상을 제작하였습니다. 생활 속에서 실천하셔서 건강에 많은 도움이 되시기를 바랍니다.
루푸스가 활성화되고 악화되는 것을 완벽하게 예측할 수 있는 그런 방법은 안타깝게도 현재는 없습니다. 그렇지만은 여러분 몸을 잘 보시면은 많이 피곤하다든지 감기 몸살처럼 쑤시고 아프고 열이 나고 입안이 헐고 피부에 발진이 생기고 머리카락 같은 것이 많이 빠지면은 루푸스 활성화를 꼭 의심해서 의사의 진찰을 받아보는 것이 중요합니다. 그래서 병원에서 하는 혈액검사, DNA 항체라든지 보체 검사 같은 것을 종합해서 의사가 활성화 여부를 판단하게 되는 것입니다. 그렇기 때문에 여러분들이 주기적으로 병원에 진찰을 받는 것은 무엇보다도 중요합니다. 그리고 다행인 것은 최근에 여러 가지 발달된 연구 기법, 유전체라든지 단일세포 분석 방법 등을 이용해서 이런 활성화를 아주 정확하게 예측할 수 있는 바이오마커에 대한 연구가 많이 이루어지고 있어서 다행으로 생각을 합니다.
안녕하십니까. 전남대병원 류마티스내과 이순석 교수입니다. 루푸스 환자분들은 햇볕에 이렇게 많이 노출이 되게 되면 기존에 있는 발진이 악화되거나 새로운 발진이 생기는 경우가 많습니다. 그래서 가급적이면은 햇볕이 이렇게 쨍쨍한 낮 시간에 활동을 하시는 것보다는 오후에, 그래서 그림자의 크기가 자기 키보다 클 때 이렇게 활동하시는 것이 권장된다고 할 수 있겠습니다. 낮에 활동을 하셔야 된다면 자외선 차단 크림을 반드시 바르시고요. 특히 SPF 지수가 30이 넘는 자외선 크림을 사용을 하시는 것이 중요하다고 하겠습니다.
운동은 고대시대에 생존을 위한 수단으로 시작되었기 때문에 생존을 크게 위협받지 않는 현대인들은 건강을 개선할 목적이 아니면 규칙적인 운동을 하지 않습니다. 그런데 여러분들은 이미 운동을 시작할 수 있는 최적의 조건을 갖추고 있습니다. 바로 루푸스라는 질병이 여러분들에게 운동의 동기를 지속적으로 제공하고 있기 때문입니다. 운동은 건강한 체중 유지뿐만 아니라 소화기관, 근골격계, 면역체계 등의 강화와 같은 무한한 이점을 제공합니다. 이미 준비는 끝났으니 오늘부터 바로 운동을 시작하세요. 그럼 어떤 운동을 해야 할까요? 너무 강도 높은 운동은 오히려 몸에 스트레스로 작용할 수 있습니다. 산책과 같이 내가 할 수 있고 또 좋아하는 운동을 매일매일 실천하세요. 운동이라는 기적의 약의 효과를 곧 느낄 수 있을 거예요. 여러분 산책길에 뵙겠습니다. 화이팅 하세요.
Hello, my name is Jazira Umarbekova. I am a rheumatologist from Kazakhstan. Systemic lupus erythematosus is a socially significant disease in the Republic of Kazakhstan and is characterized by a wide range of clinical manifestations with damage to many organs and systems and unpredictable course. The disease occurs mainly in women of reproductive age and is characterized by many different changes that create difficulties for diagnosis and successful treatment. I would like to say that lupus has many faces, and each patient has own lupus, and there are no absolutely identical variants of the course. Patients experience three shocks. The first is when they learn about autoimmune disease. The second is that they face the lifelong treatment. And the third, that they are not able to give birth. Despite the fact that the treatment of SLE has made great strides forwards and international standards are being introduced in all countries using biological preparations, one of the main tasks in the successful treatment of patients of SLE is their psychological state, and our task is to find the right interaction with the patients. In the Republic of Kazakhstan, there is a community of patients, lupus.kz. Our task is to make friends with the wolf and so that butterflies fly around it. So bye!
Всем огромный салем из Казахстана. Меня зовут Базарова Жанна. Я основатель и руководитель пациентского сообщества «Люпус Казахстан». Мой диагноз – системная красная волчанка. Я, так же как и вы, знаю, как важна поддержка близких, родных, друзей. В этом году нам исполняется 5 лет. 5 лет упорного, кропотливого труда на пути к здоровью. Мы очень гордимся нашими проектами, которые помогают нам не сдаваться перед трудностями. Благодаря помощи докторов нам удалось реализовать образовательный проект. Там нас учат правильному отношению к своему здоровью, ответственному отношению к своему здоровью. Благодаря психологам нам удалось воплотить в жизнь проект психологической поддержки девочек. Проект психологической помощи и проект преображения дает нашим девушкам веру в себя, веру в собственные силы, помогает нам не забывать о том, что мы женщины, мы красивы и любимы. Девиз нашего сообщества «Вместе мы сила». Давайте объединяться, встречаться и радоваться жизни.
Hello, this is Yoshia Tanaka. I'm a convener of SLE SIG. So APLAR has about 15 special interest group SIG in each field. SLE is one of them. So from 2020, SLE SIG has broadcasted the webinar in May to celebrate World Lupus Day. World Lupus Day is usually held in May 10th. So this year, it was also held in Wednesday this week. So to celebrate World Lupus Day, today we have a SLE webinar in the APLAR region. So next slide, please. Today, we'll have 4 wonderful presenters from each country in the APLAR region. Next slide, please. Yeah. So I'll show the faculty later, but if you have a question, please set Q&A code. We will have a Q&A session after each speakers, about 5 minutes. Next slide, please. Okay, I'll introduce the first speakers. Our speaker is Dr. Natalia Chen. She's a council member of American Society of Rheumatology. Her title will be a review of disease activity indexes in SLE. Dr. Chen, please.
Thank you. Thank you, Professor Janaka, for the introduction. And then thank you, Joyce, for sharing the slide. Thank you for inviting me to talk in this lupus, World Lupus Day webinar organized by the APLAR Academy. I'm Natalia Zhou. And today my role is to give you a review of the disease activity indexes in SLE, which I hope will be clear and comprehensive. SLE is notoriously a complex disorder. The natural cause is variable with flares and remissions. Manifestations are heterogeneous, involving one or multiple organs. Involving activities may be varied between the patient and within the same patient over time. Measuring of the disease activity remains challenging and demanding, as there is absence of gold standard to define disease activity, with diverse psychometric properties of each proposed instrument and inter-rater variability in the assessment tool. Association between disease activity and chronic damage development is well established. Higher SLE, higher SLEDAI at baseline associated with damage accrual, average BILAG score per visit or total number of flares predict the negative outcome in mortality and increased damage. Measurement of disease activity is central in researches and to evaluate the clinical outcome and responses to treatment. Longitudinally, it is important for observational studies also. There are two main types of activity indexes. The first are the global score system, which measure overall activity. This includes the SLEDAI, ECLAM, and the latest SLEDARs. Second, it will be the individual organ and system assessment scales, which assess activities in single or different organs. The prototype instrument being the BILAG. On the basis of these indexes, newer composite responder indexes like the SLE Responder Index, SRI, were developed. It is derived from the BLISS 52 and BLISS 76 studies using both the Selena, SLEDAI, and BILAG with global physician global assessment. First, there should be a certain amount of reduction in the SLEDAI. Secondly, no deterioration in PGA, and finally, no new BILAG A or more than one BILAG B score should be recorded. Another composite index is the BICLA. That means the BILAG-based composite lupus assessment derived from the EBLEMS trial, composition of 5 items. It requires certain degree of improvement in BILAG, no new BILAG A or more than one BILAG B scores, and also no worsening of SLEDAI and PGA, in addition with no treatment failure. As the new composite indexes are often SLEDAI or BILAG-based, we now go more in-depth regarding SLEDAI. SLEDAI is, in fact, the global index first developed in 1985 with 24 weighted clinical and laboratory items covering 9 systems. A simple additive score of items ranging from 1, 2, 4 to 8, and the total scores from 0 to 105. The recall period is disease activity in the preceding 10 days, although 30 days extension version is also available. SLEDAI is completed solely by physician. In SLEDAI, you can see that neuropsychiatric features are heavily weighted. For mucocutaneous features and proteinuria, only new and recurrent symptoms are scored. The version is criticized for potentially missing of persistent symptoms. Therefore, SLEDAI 2000 or 2K was introduced in 2002, which is a modification of the original SLEDAI. It allows documentation of persistent disease activity in items, including rash, alopecia, mucosal ulcers, proteinuria. SLEDAI 2K was validated against the original version and proved to be sensitive to change over time. In this version, the phrases of new or recurrence are deleted from the items of rashes or alopecia. Selena SLEDAI used in the Selena study in 2005 was modified from SLEDAI. Several descriptors were modified, including the seizure, pericarditis, pleurisy, episcleritis, and proteinuria description. 3 elements are included. Firstly, the Selena-SLEDAI score ranging from 0 to 105. This is similar to the original SLEDAI version. The PGA-VAS range from 0 to 3, with 0 indicating inactive disease and also 3 indicating severe disease. You can see the PGA here. On the other hand, thirdly, we should also include the definition of flares according to change in clinical feature and treatment of PGA. For example, adding a cyclophosphamide or azathioprine would already indicate severe flare in the disease activity. In SLEDAI, the subcategories of disease activities are also existent. A score of 6 or more, it indicates as active disease or at least moderate disease activity. Scoring more than 10 would mean high disease activity. SLEDAI has the strengths of being valid, reliable, and sensitive to change. It can determine damage accrue and predict mortality. It is also comparable to BILAG and ECLAM. It's also practical and simple to score, with flares and definition available in the Selena-SLEDAI version. On the other hand, the weaknesses include inability to capture improvement and deterioration. It's less sensitive to change compared with other instruments. The total score only reflects the overall activity, but not severity of each organ. It can't be scored until the lab results are available. Now we move on to talk about BILAG. It's an organ-based ordinal activity scale first published in 1988. Updated version BILAG 2004 was published in 2005. BILAG 2004 removed the vasculitis and added 2 new systems, the GI and ophthalmic. There are a total of 97 items or symptoms and divided into 9 systems. Each item is recorded as 0 if the symptom is not present, 1 if the item or symptom is improving, 2 if it's the same, 3 for worsening symptom, and 4 for new symptoms. Each system is then classified and transitioned into category A, B, C, D, or E. BILAG further categorizes disease activity into 5 levels, from A to E. A means severe disease, B means moderate disease activity, C is the mild stable disease, D is the inactive disease, but the system has previously been affected and now become stable. E means the system has never had any disease activity. The recall period is 4 weeks. It's also completed by physician. Flare definitions are available for BILAG. 1A score in any system indicates a fifth flare. 2 or more B scores mean moderate flare. Mild flare is 1 B score or 3 or more C in any system. Numerical scoring facilitated comparison with global indexes, with A being equivalent to 12 points, B equals to 8 points, etc. Here's a BILAG 2004 index form. There are a total of 97 items covering 9 systems. In order to better explain its use, because it's rather complicated, we have a patient as an example who had a mild myositis and moderate arthritis at the diagnosis of SLE. At the second visit, she had similar mild myositis, worsening moderate arthritis, developed new severe bullous rashes. She therefore scored 4 here, meaning new arising severe bullous rashes. 2 marks here means the same mild arthritis, and 3 marks here meaning the worsening arthritis below. However, the hard work doesn't end here. We need to cross-check with the long glossary. A score of 4 in the bullous rash is regarded as category A in mucocutaneous system, while 2 or 3 in arthritis and myositis items would be translated into category B in musculoskeletal system. Therefore, the patient had A score in the skin system and also B score in the musculoskeletal system. And the ultimate BILAG score for this patient will turn out to be EA, EB, and follows by 5 E's here, and you can see. And also, this means that she had a severe activity in the skin, moderate activity in the musculoskeletal system, and she fulfilled the definition of severe flare as she had 1A score. BILAC has the strength of being sensitive to small change, able to detect improvement and deterioration. It can show activity in individual system at a glance. Flares definition are clearly available for BILAC, but it also has the pitfalls of being complex and time-consuming to execute. Furthermore, well-defined glossary, long scoring instruction, and formal training for usage are usually essential. Although BILAC is more complicated to use, if we compare BILAC with SLEDAI, using the same patient with mild myositis and moderate arthritis at the diagnosis, and then similar mild myositis worsening moderate arthritis, and who develop new severe bullous rashes at second visit, we can appreciate the advantage of BILAC. By using SLEDAI, this same patient had 8 marks at the diagnosis. At the second visit, she had 10 marks because of the new bullous rashes. So at most, she had moderate disease activity and moderate flare. But with BILAC, she actually has severe activity in skin and severe BILAC flare. Previous studies have also demonstrated that SLEDAI is less able than BILAC 2004 to detect active diseases requiring increment in treatment. Both indexes are good at distinguishing severe and no flares. Problems only arise mainly in capturing and defining mild to moderate flares. Having said that, several years ago, I had a review under supervision of Professor Eisenberg, analyzing the data of disease activity in UCL Lupus Clinic. BILAC 2004 is shown to be capable of capturing and differentiating mild and moderate flares. And you can see the percentage of mild to moderate flare here in this circle. As BILAC 2004 may be difficult and time-consuming to use, EC-BILAC is developed and aims to become a validated and simplified tool for scoring the original BILAC 2004 index. It incorporates a glossary definition immediately adjacent to each clinical item. A new color coding system directs clinician instantly to the overall A to E score for each domain without using the long glossary. EC-BILAC was presented in EULAR 2021 as a poster and facilitate more rapid and accurate scoring of BILAC 2004. For completion of validation, it will be made widely available to clinicians. Now, the third index would be the European Consensus Lupus Activity Measurement ECLAM, which is again a global score index with 33 items covering 10 systems, plus the use of ESR and complement levels. The recall period in disease activity is in previous 1 month. Like SLEDAI, ECLAM has different weighting for various items, and you can show in this chart. The strength of weaknesses are tabulated in this table. It is still reliable, valid, and sensitive, comparable to other indexes, and quite easy to use because you can just score the symptoms according to the chart. But again, it may miss the changes over time. Finally, is the latest index, SLE Disease Activity Score, the SLEDAS, which is a continuous global score of disease activity derived and validated in 2019. The recall period is also 30 days and completed mainly by physicians. It has 17 weighted clinical and laboratory parameters, including 4 continuous parameters for arthritis, proteinuria, thrombocytopenia, and leukopenia, with the other items scored dichotomously, being present or absent. Final SLEDAS score is the sum of all the 17 weighted items according to this sophisticated formula. But no worries, online calculator is available to help the clinician. SLEDAS gives lower score to mucocutaneous than systemic vasculitis. It also gives lower score to localized skin rash than to generalized skin rashes, hence improving the weighting system. Infrequent but important SLE manifestation absent from SLEDAI are also included in SLEDAS. Examples are of homological, cardiac or pulmonary hypertension, interstitial lung disease, gastrointestinal and hemolytic anemia are also added in the SLEDAS. These items were not included in SLEDAI. This is the user-friendly online calculator, and you can easily find at SLEDAS@EU. And you can just input the symptoms accordingly into the calculator and input the joint count as rheumatoid arthritis, proteinuria level, platelet count, and white cell count, and then the SLEDAS score will be automatically calculated. SLEDAS more accurately measures the SLE disease activity and better assesses changes over time. It has a high activity, a correlation with both SLEDAI 2K and PGA. SLEDAS performs better than SLEDAI 2K in sensitivity to detect clinically meaningful change, while preserving high specificity. It also better predicts the damage accrual compared with SLEDAI. More importantly, there are clear cutoff values in defining SLE disease activity categories. Below 2.08 is remission, more than 7.64 for moderate and severe disease activity. In between would be the mild disease activity. A score change of more than 1.72 signifies meaningful worsening or improvement. Two SLEDAS-based definitions are also available for SLE clinical remissions as below, one Boolean-based and another index-based. Boolean-based defines remission with 0 or absent SLE SLEDAS clinical items plus prednisone less than 5 mg per day. Index-based defines remission with score equal or less than 2.08 with prednisone less than 5 milligram per day. Both index show high performance in validation and consistent with the DORIS clinical remission criteria. The pros and cons of SLEDAS is again tabulated here. One point of note is that SLEDAS provides definition for clinical remission and clear cut-off scores for different categories of disease activities. Hence, can be used for treat-to-target strategy like rheumatoid arthritis and adjusting treatment accordingly. Last but not least, we should use validated index to define remission or lupus low disease activity state. Remission and LLDAS are important targets in SLE. Let's say that in DORIS definition or any other definition remission, a validated index must be used. For example, SLEDAI must be equal to 0, BILAC 2004 D or E score only, and ECLAM being 0. We should also incorporate lab assessment and PG into the definition of remission. Both DORIS clinical and complete remission and LLDAS use SLEDAI to define remission, serology, PG, and also drug regimen ceiling to complete their definition. That's why knowledge and usage of activity indexes throughout daily practices are so important. So in conclusion, many SLE disease activity indexes show validity, reliability, sensitivity to change, although there's no gold standard has been identified. SLEDAS may make treat-to-target strategy more manageable in daily practice and easy to use. Evaluation of activity by a specific index is strongly recommended. Choice of the index should be governed by clinical and research interests. Disease activity indexes should be applied consistently through proper training. Thank you very much, and question and welcome. Thank you.
Okay, thank you very much, Dr. Chen, for the very comprehensive lecture in terms of disease activity scoring. It is very important. So now it's open for Q&A. Are there any Q&A? Please check the bottom of the screen of Q&A button if you have questions. So far, nothing. So may I have one question. For patients with rheumatoid arthritis, I routinely use SDI or CDI, which are very helpful to manage patients and also to reconsider treatment. So for patients with SLE, which measurement do you recommend best if you use in routine clinical work?
In my own clinic and in my team rheumatology unit, my colleagues and I usually will use the SLEDAI 2K and the Selena SLEDAI to score the disease activity, which we use in the daily practice very frequently, and I find it very useful. However, as shown in my presentation, it has the disadvantage of missing changes over time, and all those items are scored dichotomously, only yes or no, and then score accordingly. So may miss the changes of platelet count, white cell count, because these kind of parameters may change over time. And also it may miss the joint count, the arthritis. The patient may have one joint count in one visit, and then in the other visit, she may have like 5 joint counts. So it may miss the deterioration. So I would say that to supplement that, BioLab would be very, comprehensive, because I was trained in UK under Professor Eisenberg. I would say it's a very comprehensive tool, but really time consuming. So now I can see that for the latest LIDARs, because it has the dichotomous item scoring, as well as 4 continuous scoring, including we should record the joint count, platelet count, white cell count, and proteinuria. These data should be a mixing of both scoring systems. I would say that it may give us some hope and an advantage of using it in clinical practice. And most importantly, the online calculator, I find is very handy. So I may change the practice to use LIDARs in the near future.
Okay. Another question has come out. Which remission definition do you use in your daily practice?
I will prefer to use the DORIS clinical remission, because it say that the clinical items are all absent and the patient has apparently no clinical symptoms. However, the serology, some active serology is also allowed, and I find this kind of patient to be pretty stable. But according to reasons that the APLAR does would be a very good substitute, or still a very good target to achieve, because not all patients can achieve the DORIS clinical remission. But I would say we should aim for at least the APLAR does, and then we can further push to see if the patient can achieve DORIS clinical remission.
Yeah, I fully agree with you. First purpose of outcome should be ALL DAS, which
Right,
should be
yes.
treated.
Agreed.
Then, if patient achieve ALL DAS, next outcome should be DORIS remission. So I perfectly agree with you.
Yes.
Okay, it's time to move on. So thank you very much again, Dr.
Thank you.
James. So next speaker will be Dr. Elaine Vejigas from Philippines. She's a lifestyle medicine specialist and also Antique Medical Center. So her title will be Lifestyle Medicine for SLE Patient. Dr. Vejigas, please.
Okay, so good afternoon, everyone. Thank you for this chance to share about the effects of lifestyle medicine for SLE patients. So I have no disclosures. So let me just start this off by saying that our human body is the best work of art. This is because even with the smallest glitches in our health, our body knows how to repair and find the right tools. And only if we give it the proper love and care and restoration that it needs. So really have an amazing body. So for this afternoon, these are my objectives. I'm going to discuss about the healthy life and its 6 pillars, the connection of gut microbiome and autoimmune disease, and the impact of healthy lifestyle in SLE. So lifestyle medicine is a medical approach that uses evidence-based therapeutic and behavioral intervention as a primary modality to manage chronic diseases, not only to prevent, but also to treat and reverse lifestyle-related diseases. So autoimmune disease, like SLE, is very much, aside from genes, is really lifestyle related. So these are the 6 pillars in which lifestyle medicine stands. So these are also the pillars in which our bodies heal naturally. It's through the food that we eat, through sleep, exercise, if we have positive relationship or connectedness with people around us, and if we manage our stress well, and avoiding substance use like alcohol, smoking, and illicit drug use. And amazingly, man eventually learned how to invent conventional medicine. Nowadays, now that we're living in a very westernized world, a very stressful world, we have increased infectious habitat, we have less physical activity. So in a way, especially in lupus patients, especially in moderate to severe flares, conventional medicine could really save lives. But as clinicians, we know that conventional medicine also is a double-edged sword. So immune tolerance or loss of tolerance is a very important factor in the emergence of autoimmune disease, because loss of tolerance means that there is a malfunction in the immune system wherein our immune system fights its own healthy cells. So this eventually creates chronic inflammation. So just like SLE, since it involves multi-system organs, and it could create significant morbidity and mortality, especially in lupus nephritis patients. And even despite the standard care, it is still associated with end-stage renal disease and even death. Genes is already established in the pathogenesis of SLE, but there are twin studies that says that genes alone is not enough to stimulate autoimmunity. So here comes the role of the environment. We have the UV light, the infection, the food, the stress, the trauma, the obesity. So these factors through the epigenetic mechanisms, they create an abnormal immune response in these genetically predisposed individuals. And this eventually creates inflammation and immune complexes, and gives the symptoms of rash, nephritis, arthritis in lupus patients. So if we do not prevent or treat immediately the inflammation, this could involve major organs and cause significant morbidity and mortality. So autoimmune disease falls under the umbrella of non-communicable diseases, just like all other NCDs. And NCDs is deeply rooted in lifestyle as the root cause of the disease. Lifestyle means poor diets, poor sleep, poor nutrient deficiencies, lack of exercise. So these poor lifestyle habits create chronic inflammation and eventually NCDs. Okay, food, it has a very big impact. If we look at ourselves right now, it is due 80% of the food that we eat. So if food is a very big factor in the emergence of the disease or in our present health right now, so it's wise to say that food is also the medicine, because our present diet is more into processed foods and less on plant foods now that we are more on the westernized lifestyle, so Western food, okay? So how does chronic inflammation begin? So as Hippocrates said, our health starts in our gut. So it is basically made up of 3.3 million microbial genes. So it's approximately like 60% of our human body. So it's like we're only half or less than half human, because we are made up of 60% microbes. So that means we are more of bacteria, fungi, and protozoa and viruses. But these microbes really play a big role in our immune system. So it's supposed to boost our immune system and create nutrients for the body. But the quality or the kind of microbes depend on the food that we eat. If we feed these microbes healthy food, then it protects us. But if we feed them unhealthy food, then it creates chronic inflammation and sickness. So how do we resolve chronic inflammation? First is to repopulate the gut bacteria. Because when you come from a very unhealthy diet, you deplete the good bacteria in your gut. So to repopulate, we are advised to ingest probiotics, but these probiotics should come from food like tempeh, like kombucha, like yogurt, like kimchi. So these are our probiotics. We can buy them in stores, but just make sure that they contain live organisms, because not all fermented foods are truly probiotics. So once the good bacteria are inside our gut, they need food to survive. So their favorite is fiber. So they munch this fiber and they create short chain fatty acids. And these short chain fatty acids are very important in lowering down gut inflammation. And if we want to create good relationship with our gut microbiome, we have to feed them right. So they thrive in high fiber, whole foods, and minimally processed foods. So when we say whole foods, these are beans or legumes, fruits, vegetables, and potato chips doesn't count, even if it's plant, because it's really very processed. Okay, so it should be minimally processed. So if we want to, for example, if we want the bad guys to thrive inside our gut, so we eat a lot of these saturated fats. Okay, so when we eat a lot of food rich in cholesterol, trans fats, low fiber, highly processed foods, this dysbiosis happens. So when there is dysbiosis, there is increased inflammation in the body, and then NCDs emerge. So these are the evidences on lifestyle and lupus. Nutrition so far has been extensively studied when it comes to SLE, and one of these is omega-3 fatty acid in the form of EPA and DHA. So these are anti-inflammatory, and this has been to reduce disease activity and inflammatory markers, and as well as endothelial function and dysfunction and oxidative stress. Omega-3 fatty acids can also lower serum creatinine in lupus nephritis patients. So we find this in chia seeds, flax seeds, fruits, vegetables, and fish. Studies also show that vitamins A, D, E, and C have anti-inflammatory effects that can decrease inflammatory markers in SLE patients. Vitamin D supplementation in vitamin D depleted patients was seen to decrease disease activity, and all of the rest, they decrease oxidative stress, which is a big reason for SLE flares also. Turmeric, one of the herbs that has been studied for a long time in inflammation. With curcumin as its very active ingredient, turmeric supplementation can decrease proteinuria, hematuria, and systolic blood pressure, and it's seen to be a safe adjuvant therapy for lupus nephritis. And whole food plant-based diet, this entails to beans, fruits and vegetables, nuts and seeds, and this is shown to improve chronic low-grade inflammation, and this may be due to the high fiber content of these foods. And whole food plant-based diet also improves disease symptoms, mood, and could induce weight loss. And at the same time, it could improve glomerular filtration rates and decrease serum creatinine. So excess weight was associated with increased clinical activity. So excess weight in lupus patient can be due to unhealthy diet, poor physical activity, and even the side effects of steroids. And as we all know, adipose tissue is already inflammatory. So when you have more adipose tissues in your body, you become more inflamed. So we don't want this on top of an existing lupus flare, inflammation after inflammation. So really decreasing weight could help reduce inflammation in SLE patients. And group mindfulness-based stress reduction. These are stress managements for SLE patient. Because we all know SLE is really stress-related. So many of my patients come from flares, emerge because of trauma, of stress, and having people around them, accountability, partners, it really improves their mental health. Okay. So when it comes to smoking, I think smoking has already established its role in increasing the risk of SLE flares as well as elevating dsDNA. But alcohol in moderate doses, it seems like studies show that it can be protective against the development of SLE. But as you could see, we should not think of just SLE per se when it comes to alcohol consumption, because alcohol consumption by itself increases the risk for cardiovascular diseases as well as cancer. So I think this would be a good enough reason for us not to place alcohol in our prescriptions. And of course, physical activity really has its advantages, not just in SLE patients, because research says that their SLE patients are really engaged in poor physical activity. Okay, so physical activity is not contraindicated in SLE patients. Actually, it could boost energy. It is tailored according to the fitness level of each patient. So it's every patient is unique, and exercise also showed to improve exercise tolerance, aerobic capacity, the quality of life, and even depression. So sometimes as clinicians, we want to get the message through to all our patients, but sometimes it doesn't. So we don't want this to happen. So what does lifestyle medicine do to get this message or these prescriptions through our patients? So we call this behavioral counseling or behavioral intervention. This means that each patient that we meet are in different stages. So on each stage the patient is in, there is a corresponding management or intervention. For example, if the patient is in pre-contemplation or contemplation stage, the best intervention is motivational interviewing. Okay, so I'll be a very, very lucky doctor if I don't get this many reactions from my patients, especially on the first and second visits, because it's not usual for a doctor to place on their prescriptions green smoothies, 3 tablespoons of flax seeds, chia seeds, regular exercise, get some early morning and late afternoon sunlight, So I'm glad that at this point I've learned how to deal with these patients, and really treating patients is really an art. And for my clinical experience, we use shared medical appointment. So shared medical appointment is like a group counseling. So since behavioral intervention takes a very long time, you cannot advise patients in just 10 to 15 minutes. Okay, so and if you have a lot of patients, it'll take until nighttime to finish the clinic or even the next day. So the technique here is to group them together. Okay, so this is our SMA programs. So what we do is we do both online and on-site, wherein we even have patients as far as outside the Philippines. Okay, so we do this like once a week, and then we meet and submit laboratories. We apply the 6 pillars of medicine, and this is we teach them meditation to manage their stress. They talk to each other, they share, and we give them lectures. We teach them exercise. Exercise is tailored on the fitness level of each patient. So after the lectures, we teach them how to make their meal plans. We educate them on how to choose good food, healthy food wherever they are. And we teach them exercise. And because all of my patients seems to be very busy people, we teach them how to make smart meal preparations that still are healthy. And I'd like to share with you 26-year-old Anne, who has lupus nephritis and MSK flare last 2017. When I first saw her, she was in flare. I placed her on azathioprine, HCQS, high-dose steroids, and at the time, she had an unhealthy lifestyle. So that means stressed out, unhealthy food, more unprocessed food. My lifestyle management started in 2021 because this was the year that I got certified as a lifestyle medicine doctor. And after 10 months of treatment, she was in complete remission and presently on azathioprine holiday. But sadly, she came back to her unusual unhealthy diet, and she came back with high sugar, skin flares, and again, advise her healthy lifestyle and place her on 1 week low dose steroids. And up until now, she's 1.5 years complete remission on HCQS and healthy lifestyle. So 45-year-old Feli, who has lupus and lupus nephritis, 2019, placed on the regular armamentarium of lupus nephritis. She had the cyclophosphamide chemotherapy. She finished cyclophosphamide 2021. And from January 2022 up to this year, a total of 1.5, she maintained to be in complete remission on HCQS and lifestyle. So this is 24-year-old Len. To 2022, lupus nephritis started her on high-dose steroids, HCQS. Ren is actually a very meat eater. She eats also egg 1 to 2 pieces every day. And at that time, she was reviewing for exam and she was very stressed. So I advised her healthy lifestyle. She was okay until 2 months. She gained weight again. She bounced back. She resumed her meat diet. She again had proteinuria, hematuria, and I restarted her again on steroid. And then 2 months after, I tapered her steroid off, and she had actually mild COVID. And luckily, she recovered from COVID with no COVID medications, just supportive care. And she's complete remission for 6 months now. Okay, Rexy is 4 years old. She's newly diagnosed with lupus nephritis. She presented with edema, high cholesterol. It's twice elevated. She loves fast food, especially French fries, because her mom doesn't have time to cook for food because she's a very busy mother. So at the time she had twice elevated creatinine, SGPT, and proteinuria. So I placed her on the usual conventional treatment and also healthy lifestyle. So after 2 weeks of plant-based diet, so the plant, because sometimes it's difficult for children if they're used to fast food. So what we do is we teach the mothers to make green smoothies so they can be very tasty. So after plant-based diet, she had normal creatinine, urinalysis, cholesterol, and SGPT, and eventually was off steroids. And after 2 months of healthy lifestyle, no steroids, and she's due for follow-up next month. Okay, so there can be many relapses in even with healthy lifestyle, because so what we do is that we counsel them again on where they are at, and then we go back, we trace the root cause, and then we manage them. So when it comes to pedia patients, we educate also the mother or the caregiver or whoever is taking care of the pediatric patients. So it's very important because to have a supportive family or people around this special population. So we have to learn how to turn off the faucet as clinicians, as rheumatologists, because turning off the faucet actually is treating the root cause of the disease. We have to look into the lifestyle of these patients, because mopping the floors is very tiring when the faucet is on. So eventually, physicians suffer from burnout. This may be also the reason why medications are hard to be taken off the patients, because they have unhealthy lifestyle. So if we take time, if we educate, and if we empower these patients through behavior change, we could really prevent physician burnout and help our patients. So this is a very nice saying from Hahnemann that the highest ideal of cure is the speedy, gentle, and enduring restoration of health by the most trustworthy and least harmful way. So our patients trust us to optimize our care and to treat them. So I hope this will bring into mind every time that we treat our patients. And to give optimal care to our patients, may it be lifestyle medicine, conventional medicine, or the fusion, the goal is to prevent illness, to optimize health, and to even reverse autoimmune disease. Okay. So I always tell my patients that even if you're very rich and you can buy the most expensive medicine, conventional medicine will only do almost half of the time, or almost always they will do half of the job. Because why? If we do not correct the lifestyle of our patients, they will not get better. So hope and empowerment is what we teach these patients. And with lifestyle medicine, I hope that we continue to give it to them so they can be empowered and they can take control of their life. Thank you.
Thank you very much, Dr. Venegas. It's a wonderful lecture to enhance our spirit and also our attitude for the patient management. Now you have at least three questions. Okay, one is, I just recently diagnosed with SLE. What exercises advised for SLE patient? Are we allowed to do jogging?
Yes and no. So the answer is that you have to identify your fitness level. When we say mild exercise, you can do walking. Like moderate exercise, you can do jogging. But sometimes the moderate exercise can be a hard thing to do if you come from a very sedentary physical activity or lifestyle. So what you do is you assess yourself and you have to tailor your physical activity according to your fitness level. If jogging, you get shortness of breath or you get fatigue with jogging, so why don't you just do long walks? And if you can do long walks, why don't you do the walk and jog before you do the full jogging? So it's like individualized. So you have to really listen to your body.
Okay, thank you. Next question is that, so what is your definition of healthy diet for lupus patients? Do you regard meat or egg as pro-inflammatory?
Yes. Healthy diet is what I've mentioned in the slides, is about majority of our plate should come from whole foods. So when we say whole food, they have undergone minimal processing. That means that less nutrients have been removed. And like, for example, if we want to pick a banana on the tree and you eat it directly, that's whole food. It did not undergo any processing. So boiling a banana is also good, but not making it a banana chip with the sugar. So healthy diet is like eating it as in its most natural form. And eating meat is really pro-inflammatory, as well as eggs. So any animal meat, for that matter, is pro-inflammatory.
Thank you. Next question is important. Steroid, glucocorticoid, is also bad for inducing weight gain. So what is your advice on diet when they are given induction steroids?
Okay, so steroids is really life-saving, especially when you need it. But the side effect is really weight gain. Okay, so what do? Is we lessen, the important thing is we lessen the side effects of the steroids. So my advice is still to eat whole foods, fruits and vegetables, as not to gain weight, and not to eat a lot of highly processed food. Okay, so you don't get the trans fat, the saturated fats in large volumes. So majority still of your diet is plant, like it's 95% plants, whole food.
Thank you. Next question. Maybe this is the last question because of the time. So what are the foods that are lupus triggers? For instance, garlic, bean, sprouts, and etc. or coffee.
Okay, so plant food so far hasn't been seen as pro-inflammatory in autoimmune disease. Okay, so garlic is very good, especially in cardiovascular health. Bean sprouts are very high in nutrients and very high in fiber. So we are even advised to eat beans half cup of serving a day. So these are really nutritious foods. Is coffee bad? Coffee depends upon if you have like cardiovascular problem, if you have tachycardia, fast heart rate, wherein caffeine is contraindicated to you. A plain black coffee, if you have no other medical contraindications, you can take it with no creamer, just plain black coffee with like a cup a day, not more than that. And also, otherwise, coffee is a good antioxidant.
Yeah, thank you very much, Dr. Benincles. It's wonderful. So it's now time just to move on next speakers. Well, thanks again. Next speaker will be Professor Lantana Katistanon from Thailand. She's a doctor in Division of Rheumatology, Department of Internal Medicine, Faculty of Medicine, Chiang Mai University, Thailand. So her topic will be better understanding of neuropsychiatric SLE, pathomechanism, and management. So Professor Katistanon, please.
Thank you. Thank you, Professor Tanaka. Good afternoon, everyone. I would like to present the better understanding of neuropsychiatric SLE pathology and mechanism and management. Neurologic and psychiatric manifestation in SLE reduce health-related quality of life. In Asian countries, neuropsychiatric events attributed to SLE are common, 4 to 19% at diagnosis and 6 to 40% during the course of the disease. Usually, NPSLE occur at disease onset or within the first to second years after diagnosis. The good news, the study from SLEEK group show the resolution of the NPSLE is more common in patients of Asian race. From our study at Chiang Mai University, 127 neuropsychiatric events, 2/3 attributed to SLE, 1/3 attributed to non-SLE. Therefore, if the SLE patients present with the neuropsychiatric events, we have to exclude the non-SLE causes. Psychiatric problem, emotional stress, CNS or systemic infection, or their comorbidity like metabolic disease, thyroid disease, tumor, and their medication, steroid, statin, and CNS suppressant. If we exclude non-SLE causes, then the neuropsychiatric events may attribute to SLE. We call primary NPSLE. In 1999, American College of Rheumatology gave a nomenclature for NPSLE. They defined 12 central nervous system manifestations, including diffuse and focal, and 7 peripheral nervous systems. The neuropsychiatric in SLE have variety of severity. For the headache, mood disorder, anxiety disorder, mild cognitive dysfunction, and polyneuropathy are the most common complaints from the patients. However, these symptoms are not specific, no specific history. investigation or imaging. Therefore, ANNIALAR study found if exclude this symptom, specificity of DIAC and PSLE increased from 46 to 93%. For the prevalence and incidence of each manifestation, vary among study due to the study design or the definition. However, most studies mention that seizure disorder and cerebrovascular disease are the most common in PSLE. In 2019, EULAR and ACR classification criteria for SLE include the acute confusional state, psychosis, and seizure in the new classification. Outline for today is pathogenesis, diagnosis, and treatment in NPSLE. The pathogenesis in NPSLE align with different neuropsychiatric manifestations. For the diffuse central nervous system manifestation, the major pathogenesis is inflammation, induced injury, and blood-brain barrier permeability. After the blood-brain barrier injury, endothelial cell leak, and then autoantibody, immune complex, and inflammatory cytokine can access brain parenchyma and activate microglia, astrocytes, and damage neuron. The role of specific autoantibody in the mice model show that subset of anti-DNA against NR2 subunit of NMD receptor and anti-liposomal P can induce neuron apoptosis. And then anti-SM, anti-RNP, and anti-liposomal P can enhance inflammatory cytokine production in human monocyte. Also, anti-aquaporin 4, the marker for the neuromyelitis optica, can found in SLE and can induce the astrocyte. Other element, the study found in CSF and in serum many cytokine, interferon alpha, tumor necrotic factor, and MMP increase. There are many attempts was made to show the association between the biomarkers and PSLE manifestation. Anti-liposomal P associated with psychosis and depression. Anti-liposomal P also associated with memory impairment. Anti-DNA NR2 associated with psychosis, behavioral change, cognitive dysfunction. Anti-phospholipid antibody associated with seizure, chorea, headache, and myelitis without any sign of thrombosis. And then recent literature report the diagnostic biomarker in NPSLE. For the cytokine, interleukin 6 is the outstanding inflammatory cytokine that have ability to discriminate diffuse NPSLE from the non-NPSLE with high area under the curve 0.89 and high sensitivity and specificity. For the autoantibody, in patients with diffuse NPSLE have higher prevalence of anti-liposomal P and anti-cardiolipin when compared with non-NPSLE patients. The pathogenesis in focal manifestation, ischemic from microangiopathy and thrombosis is the major pathogenesis. The cause of thrombosis in SLE factor is antiphospholipid antibody. The other cause is immune complex and inflammatory cytokine may induce thrombosis. From the study show the patient with focal manifestation has higher prevalence of anti-cardiolipin, anti-beta-2 glycoprotein 1, and anti-SM, higher than non-seizure and non-NP-SLE patients. However, some manifestation may the combination of inflammatory and ischemic pathogenesis. Next is diagnosis. I would like to present the patient, Miss A. She is a 30-year-old woman. 3 weeks before she was referred to our center, she was diagnosed SLE due to discoid rash, Mara rash, ANA, and anti-double strand DNA positive. She had blurred vision. At that time, she was retinal vasculitis and pushed on prednisolone 50 milligrams per day. After 1 week, she was admitted to the hospital nearby her hometown because of weakness of both legs, urinary incontinence. 1 week after admission, she developed a generalized chronic tonic seizure for 2 minutes. After that, she developed fever and confusion. Then she was referred to our center. Physical examination revealed high fever, alopecia, Mara rash, active discoid rash, and basal at sacrum. Neurologic examination, she awake, but she had aggressive behavior, disorientation. She has weakness of both eye and sensory decrease under T4 level, lost anal sphincter tone. The investigation showed anemia and leukocytosis. However, no obvious infection site demonstrated. Her urine showed albuminuria, and she has high ESR, high anti-double strand DNA with low complement. Therefore, our assessment, she has high disease activity. Her fever may from SLE itself or from the infection. Neuropsychiatric events that she has, just 1 episode of seizure, acute confusional state, and paraplegia. For the differential diagnosis, acute confusional state may from lupus encephalopathy. However, we have to exclude non-SLE cause, infection, metabolic cause, electrolyte imbalance, toxin, or steroid-induced psychosis, or other NPSL neuropsychiatric events, for example, schizophrenia or epilepsy. For the paraplegia, transverse myelitis is suspected. However, we have to exclude extramedullary lesion, for example, cord compression, reticulomyelitis from infection, and demyelinating disease. What would you like to investigate in SLE with neuropsychiatric manifestation? The answer is it depends on what the expectation causes. If the patient has cerebrovascular disease, antiphospholipid syndrome should be tested. CSF may test if you would like to exclude the infection. Electrophysiologic study may did in patient with seizure or polyneuropathy. Neurologic assessment in patient with cognitive impairment, and neurologic imaging for define the structure of functional chain. For the neuroimage, the aim of the neuroimage are localized intracranial abnormality, distinguish white matter from gray matter disease, identify changes in cerebral blood flow and volume. MRI is the most helpful morphologic neuroimaging because MRI can detect abnormal lesion 75% in NPSLE. And then MRI very sensitive, can present the intracranial lesion, particularly the large lesion, for example, cerebral atrophy, infarction, hemorrhage, abscess, tumor, or transverse myelitis. Patient with NPSLE had higher white matter lesion volume than patient without NP and healthy control. However, the MRI lack of correlation between clinical and structural abnormality in diffuse NPSLE. The MRI can show subcortical white matter hyperintensity 20 to 50% in patients without neuropsychiatric symptoms, and 50% of patients with diffuse neuropsychiatric in SLE have normal finding. For the functional technique, the PET scan is the most available technique that we use in clinical practice. The PET scan can explore both brain glucose metabolism and cerebral blood flow. PET scan can detect multiple areas of hypometabolism in patients with normal appearing white and gray matter region from MRI. PET scan has very high sensitivity, but low specificity and limited availability and excessive cost. Therefore, we preserve the PET scan for the patient who has normal MRI but had high suspected NPSLE. For example, my patient, she is a 36-year-old woman with generalized pain for 1 year. She has high ESR and ANA positive. Her MRI was normal, but when she did the PET scan showed left anterior superior frontal hypometabolism that present with light blue color. 3 months later, she had acute confusional state attributed to SLE. This may help tell us that sometimes the abnormal of metabolism in the brain can come before the clinical presentation. Back to Miss A. She has the C3 brain and show lacuna infarction and brain atrophy. Anticardiolipin and lupus anticoagulant negative. CSS examination show high protein, low sugar, but no cell and culture negative. The EEG show diffuse encephalopathy. MRI of the spinal cord show increased intensity in the spinal cord compatible with acute transverse myelitis. And then she was diagnosed acute transverse myelitis and lupus encephalopathy. As you can see, SLE patient present with neuropsychiatric problem. We have to exclude non-SLE cause. Physicians have to assess disease activity and look for the index of suspicious, and then use the clinical listening to choose next investigation. Therefore, NPSLE diagnosis still greatly rely on the skilled clinician. However, Italian group developed an algorithm for attribution of NPSLE. They define 4 items. The item 1 about the time onset of neuropsychiatric event and the onset of SLE. The item 2 is the manifestation of neuropsychiatric. And item 3 is the confounding factor. Item 4 is the favoring factor attributed to NPSLE, and with each item. The score was 0 to 10. The cut point more than 6. If more than 6 score, sensitivity and specificity for the NPSLE are 88 and 83. For our patients, her score was 10. She get 3 score from the onset of neuropsychiatric within 6 months of SLE onset. And she has myelitis and cardiovascular CVD. And then she has no confounding factor. She has 2 additional favoring factor, age less than 50 years, and high SLE disease activity. Okay, then we go to the treatment in NPSLE. For the inflammatory NPSLE syndrome, the APLAR consensus statement on the management of SLE for the neuropsychiatric SLE from the inflammatory in origin. The statement suggests a combination of moderate to high dose glucocorticoid and cyclophosphamide is the first line. And then rituximab may be considered in refractory case. Symptomatic treatment and reversal of aggravating factor are important for certain NP manifestation. We did a systematic literature review for the APLAR consensus statement. However, there are very few studies that support because of there's only 2 clinical trials that have study about the steroid and cyclophosphamide in NPSLE. First study in 2005, that study compare the patient who has NPSLE treated with methylprednisolone and cyclophosphamide compared with methylprednisolone alone, and look at the response at 12 months. The patient who had methylprednisolone and cyclophosphamide respond with 95%, while patient with methylprednisolone alone respond only 54%. Another study showed the patient who with NPSLE treated with prednisolone and IVCY had higher clinical improvement, lower relapse rate, and recovery from the EEG and electrophysiologic study than the patient who get only steroid at 6 months. For the refractory case, rituximab may be considered. The regimen may be weekly 375 mg per square for 4 doses, or 2 weekly 1 gram of 500 mg for 2 doses. Usually, most of the evidence support case series, or the case series show that treated patient with refractory NPSLE respond very high response rate after receive rituximab. Other choice, plasma exchange or IVIG, may consider in patient who has contraindication for immunosuppressive drug, for example, co-infection. For the new treatment, unluckily, NPSLE patient was excluded from the clinical trial of new treatment. However, one study in 2019 failed to demonstrate that interferon inhibitor reverse the neuropsychiatric disease in mice model. For the symptomatic treatment, we may consider seizure, psychosis, and supportive mood disorder in the beginning of treatment. However, did not every symptom have been treated, we may select only the necessary case. For example, seizure, we may give the anticonvulsant if the patient has recurrent seizure or abnormal EEG. Our study, only 26 from 53 patients with seizure need anticonvulsive agent, and the mean duration only 3 months. The rest of the patient who persist, who have to continue the anticonvulsive agent, had focal neurological deficit and had abnormal EEG. For the focal neuropsychiatric manifestation, if the thromboembolic event associated with antiphospholipid antibody, anticoagulant is required. Vitamin K antagonist is preferred for the anticoagulant, and then low-dose aspirin may consider for primary prophylaxis in patients with high risk of antiphospholipid antibody profile. As we know, cerebrovascular disease is the antiphospholipid-related ischemic stroke. However, other symptoms like seizure or myelopathy or movement disorder may be the NPSLE strongly linked to antiphospholipid antibody. Therefore, the treatment, if the patient has antiphospholipid-related ischemic stroke, then the anticoagulant should keep INR 3 to 4 in arterial occlusion and INR 2 to 3 in venous thrombosis. However, in patients with NPSLE strongly linked to antiphospholipid antibody and has refractory symptoms, may consider the anticoagulant. For the patient who has no antiphospholipid antibody, aspirin may be considered. For our patients, in the beginning, she was treated UTI and bed sore, antipsychotic. After she received high-dose methylpenicillin and IVCY, her symptom of the psychotic symptom improved, and then the antipsychotic was stopped. After treatment 3 months, her conscious get normal and appropriate emotion. Her motor power improved. This is her appearance after treatment 3 months. In conclusion, NPSLE is multifactorial nature and clinical heterogeneity. There are no specific or standard of diagnosis. The investigation may help for exclude the other pathology. Early detection and early effective treatment prevent neurological deficit and improve health quality of life. Future study to understand immunopathogenetic mechanism of NPSLE will bring to innovative strategy of treatment. Thank you.
Yeah, thank you very much, Dr. Castaner. Now it's open for discussion. Yeah, your lecture is very educative and also very useful. So now you have at least 3 questions. First question is that how long do you usually give IV cyclophosphamide for NPSLE?
Actually, the duration of cyclophosphamide may extrapolate from the lupus nephritis regimen. Sometimes we use like 3 to 6 months and evaluate the response.
Okay, thank you. Next question is maximum dose of rituximab in PSLE.
Okay. Actually, now there is no standard regimen for the rituximab. However, in pediatric, I think the regimen 375 milligram per square weekly may be appropriate to the pediatric NPSLE.
Okay, thank you. Next question. What are the scenarios that you give methylprednisolone pulse in NPSLE?
Usually, I think we should give the methylpenicillin in very severe or the NPSLE manifestation which have be morbidity like a transverse myelitis or diffuse CNS encephalopathy.
Okay. Next question is, do you have any suggestions for treatment lupus patients with interactive CIDP?
Oh, Okay. I think maybe first of all for the CIDP is maybe difficult because there is no, first of all, there is no clinical trial and no standard. Maybe extrapolate from other severe manifestation. However, I think maybe we have to access for the anti-phospholipid antibody first. If associated with anti-phospholipid antibody, maybe use the anticoagulant. But if anti-phospholipid antibody negative, maybe we try the cyclophosphamide.
Okay, thank you. Next question. Do we treat patients with Sjogren and neurological manifestation as with in the PS3?
Yes, I think because the neurologic manifestation in children may have to extrapolation of treatment from the NPSLE because no clinical trial.
Okay. Next.
Thank you.
I was also given pulse treatment in 2011. Today, do you prescribe the use of stem cell therapy to lupus patients?
What's your pulse today? Use of stem cell, or I have no experience for the stem cell therapy.
Okay. Next is important. How do you distinguish between steroid-induced psychosis versus NPSD?
Okay, yes, this is for the distinguish between the steroid-induced psychosis. First of all, we have to look for the onset of steroid treatment. Like usually the steroid-induced psychosis may begin after high dose steroid treatment 2 weeks. And then we have to evaluate the disease activity. If the neuropsychiatric events occur when the disease very active, we may try to give steroid high dose and see how it's going, the patient improve or worsening. But in the case that patient has low disease activity and develops the psychosis, we may decrease the dose of steroid and observe for 3 days, 78 hours. If the steroid-induced psychosis, the patient may improve after we decrease the steroid.
Okay. Yeah, thank you very much. There are more than 5 questions, but it's time to move on. But thank you very much again, Dr. Kastanen. So I want to move on next speaker. Next speaker will be Dr. Po Yui Jia from Singapore. She's a senior consultant, Department of Rheumatology and Immunology, Singapore General Hospital. Her talk will be about strategies for successful maternal and fetal outcomes in SLE pregnancy. So Dr. Po Yui Jia, please.
Thank you, Professor Tanaka, for the kind introduction, and thank you for the organizers for inviting me to speak today. Okay, my talk today is really on the strategies for successful maternal and fetal outcomes in lupus pregnancy. And we all know that this is important given that lupus affects women of childbearing age. Lupus on its own has no adverse impact on fertility, and pregnancy in lupus is known to be associated with an increased risk of adverse maternal and fetal outcomes. So this is the outline of my talk today. I will discuss the current published trends in maternal and fetal outcomes in lupus pregnancies. I'll discuss with regards to the influence of pregnancy on lupus and the effects of lupus on pregnancy outcomes, and a discussion with regards to how we approach lupus pregnancies, and I'll conclude with contraception. This is a retrospective data taken from the States and utilizing inpatient data looking at lupus and non-SLE pregnancies over 18 years from 1998 to 2015. And if you look at the top two graphs, over the period of time, there was a decrease in inpatient in-hospital mortality and also intrauterine fetal death in lupus patients compared to non-SLE patients. And the bottom graph illustrates that preeclampsia and eclampsia rates fell from 9.5% to 9.1% in lupus patients. But if you look at the non-SLE patients, it rose from about 3 to 4% over the same period of time. This data looks at other pregnancy outcomes of interest. Again, this is data taken from a large health electronic record, but this is just a single center in the States over 3 decades. This really illustrates that adverse pregnancy outcome in lupus pregnancy have in fact remained the same over the 3 decades. If you look at live birth, which is the top graph, live birth was similar across the study duration. However, compared with controls, lupus pregnancies were more likely to be complicated with preterm delivery with an odds ratio of 6.7 and preeclampsia with an odds ratio of 3.22. If you look at the Asian cohort, this is a nationwide case control study utilizing Taiwan's National Health Insurance Program from 2005 to 2014, which shows very similar results that adverse pregnancy outcomes looking at preeclampsia and eclampsia confers a 3-fold risk in lupus pregnancy, 2-fold risk of intrauterine growth restriction, 3-fold risk of preterm delivery, and a 4-fold risk of stillbirth. This is data from our center. We are a tertiary referral center, and this is the data for our lupus pregnancy with a live birth rate of 75%. Miscarriages occurred in 20%, lupus flares in a third, and preeclampsia occurred in 4%. How does lupus actually affect pregnancy? If you look at the literature, variable flare rates have been reported, and oftentimes this population group is very heterogeneous. It includes both patients with very high and very low disease activity at baseline. If we hone into lupus patients with inactive or mild disease activity at baseline, and this is really data from the PROMISE study, which we'll talk a little bit more in the subsequent slides, low rates of flares have been reported. It's about 20% mild to moderate flares, and most of the moderate flares did not require adjustment of medications. There's really no difference in this cohort between lupus flares in pregnancy and postpartum flares. Younger age and higher disease activity at baseline and low complement levels are independently associated with an increased risk of flare during pregnancy. Other predictors that have been identified include the presence of renal disease and discontinuation of medications, particularly hydroxychloroquine, which increases the risk of lupus flares in pregnancy. And therefore, this is reflected in the recent ACR 2020 reproductive guidelines and the prior EULAR 2017 lupus guidelines regarding the importance of continuation of hydroxychloroquine in lupus pregnancies and to commence hydroxychloroquine if patients are not currently taking it. As I've illustrated in the first few slides, lupus is associated with an increased risk of a variety of adverse pregnancy outcomes, and this includes an increased risk of preeclampsia, increased risk of preterm birth, increased risk of intrauterine gestational intrauterine growth restriction, and an increased risk of fetal or neonatal mortality. If you look at the data from the PROMISE study, it's associated with an fetal or neonatal death of about 4%, and these are in patients with no risk factors at baseline. And comparing this with a fetal death rate of the general population, which ranges between 0.6% in the States to about 2.8% in Africa. Again, some of the predictors that have been published include the presence of antiphospholipid antibodies, presence of renal disease, hypertension, and active disease at conception. As we all know, this is the PROMISE study. It's a multi-center prospective observational study of lupus pregnancies. And in this particular study, patients with no risk factors at baseline, the adverse pregnancy outcome rate is 7.8%, fetal or neonatal death of 3.9%. If you look at patients who are non-white or Hispanic treated with antihypertensive, irrespective of their lupus anticoagulant status, the adverse pregnancy outcome rate is about 60%, and fetal or neonatal death is about 22%. I'll draw your attention to the table on the right. These are the baseline predictors of adverse pregnancy outcomes. Lupus anticoagulant confer an odds ratio of 8.3. Patients who are currently taking antihypertensives confer a risk of 7.1. Patients with active disease with a PGA score of greater than 1, odds ratio of 4, and patients with thrombocytopenia with an odds ratio of 1.33. If you look right up the top, patients who are non-Hispanic and white is a protective effect. The PROMISE study also looked at serology, so anti-double-stranded DNA positivity was not associated with an increased risk of adverse pregnancy outcome. However, a smaller increase in complement levels from baseline to the second trimester was predictive of an adverse pregnancy outcome after 23 weeks gestation. And the absence of an increase in complement levels during pregnancy may suggest complement activation, which drives poor placenta vascularization and trophoblast injury. I'll move on to the next section, which is how we approach lupus pregnancies. And really, this is an interplay between the lupus disease activity, medications, risk stratification with antibody profile, and also presence of severe organ damage, whereby one may want to counsel against pregnancy. We know that active disease increases the risk of adverse pregnancy outcome, therefore underscoring the importance of disease control prior to conception and throughout pregnancy. Active disease within 6 months prior to pregnancy is associated with a lupus flare in pregnancy, and therefore the importance of contraception during periods of active disease and while patients are taking teratogenic medications. It is important that we discuss with our patients regarding transitioning to pregnancy-compatible medications with a period of monitoring during our pre-pregnancy counseling with patients who plan conception. If you look at the ACR 2020 reproductive guidelines, it is strongly recommended to taper prednisolone doses greater than 20 milligrams daily and to consider addition of pregnancy-compatible disease-modifying medications. And we all know that both active disease and glucocorticoids contribute to adverse maternal and fetal outcomes. Glucocorticoid dosing beyond 20 milligrams is associated with gestational diabetes, hypertension, osteoporosis, preterm delivery, premature rupture of membranes, and infections. It is important to monitor disease activity in pregnancy, and we do have the SLE Pregnancy Disease Activity Index, which takes into account physiological changes in pregnancy. I think the landscape has changed quite significantly over the last several years, and we now have many different guidelines published with regards to the use of disease-modifying drugs and biologics in pregnancy and lactation, which really provides an excellent framework of how we can counsel our patients with regards to the importance of continuing pregnancy-compatible medications to ensure that the disease remains quiescent in pregnancy, and also continuation of lactation-compatible medications postpartum. This is really a non-exhaustive list of pregnancy-compatible medications that we commonly use in lupus, and these include azathioprine, hydroxychloroquine, calcineurin inhibitors, sulfasalazine. It is important that we continue folate supplementation on patients who are taking sulfasalazine. Just a word with regards to NSAIDs, non-steroidal anti-inflammatory drugs. Preferably is to use non-selective NSAIDs, and really this is due to the lack of evidence of the use of COX-2 inhibitors in pregnancy. There's a recent update from the FDA with regards to NSAIDs published in 2020, which is really to avoid the use of NSAIDs after 20 weeks due to the increased risks of fetal renal dysfunction and oligohydramnios. And it is recommended to limit the use to the lowest effective dose and for the shortest duration. The table on the right are medications that are contraindicated in pregnancy. So these are cyclophosphamide and rituximab. However, physicians could consider these medications in the event of life or organ-threatening disease in the second or third trimester after the period of organogenesis. Mycophenolate mofetil, leflunomide, and methotrexate are contraindicated in pregnancy. These are the list of medications that are compatible with breastfeeding. And again, the list is not different from the pregnancy compatible medications. I just want to draw your attention again to the use of non-steroidal anti-inflammatory drugs. Again, the recommendation is for the use of non-selective NSAIDs, for example, ibuprofen. And for glucocorticoids, the recommendation is for patients who are taking prednisolone doses greater than 20 milligrams daily to consider delaying breastfeeding or to discard the breast milk. Low-dose aspirin is important in lupus pregnancies. We've illustrated earlier that lupus pregnancy is associated with a threefold increased risk of preeclampsia compared with healthy women. Preeclampsia is a major cause of maternal and prenatal mortality and morbidity. In the 2019 Cochrane Review, it's established that low-dose aspirin taken from the end of the first trimester to 36 weeks gestation reduces the risk of developing preeclampsia by around 18%. So generally, we recommend commencing aspirin when intrauterine pregnancy is confirmed and continued until delivery. Low-dose aspirin is thought not to complicate anesthesia and delivery. And this recommendation is actually across several different international guidelines, including the American College of Obstetrics and Gynecology guidelines, the UK NICE guidelines, and also the US Protective Health Task Force. We move on to how we stratify patients according to their antibody profile. And the first antibody of interest is our anti-Ro and anti-LAR antibodies, and this is associated with neonatal lupus syndrome. Neonatal lupus syndrome occurs, as we all know, due to maternal antibodies crossing the placenta. It is associated with a 1 to 2% risk of congenital heart block, and this occurs due to an autoantibody-mediated damage of fetal conduction tissues, leading to inflammation and fibrosis, causing the blockage of signal conduction at the AV node. There are other clinical manifestations of neonatal lupus syndrome, and this includes 10% neonatal lupus rash, 20% transient cytopenias, and a third with mild transient transaminitis. And these other clinical manifestations generally spontaneously resolve when the child's maternal antibodies disappear. Irreversible complete AV block is the principal cardinal manifestation of congenital heart block, and obstetric history is the principal factor that increases the risk of this. So the risk increases from a background of 1 to 2% of congenital heart block to 16% in women with a prior autoimmune congenital heart block affected pregnancy, and 13% in women with a history of non-cardiac neonatal lupus. Mortality is around 20%, and the majority of these occurs in utero. Morbidity is high, about 64% of live births require pacemakers. The PATCH trial is actually the first prospective open-label trial that looks at using hydroxychloroquine at a dose of 400 milligrams daily prior to 10 weeks gestation, and it's demonstrated that this reduced the recurrence rate of congenital heart block by more than 1/2 compared to historical controls. And if we look at the recent ACR Reproductive 2020 guidelines, this is reflected in the guidelines with regards to the use of hydroxychloroquine in anti-Ro and anti-LAR pregnancies. Recommendations regarding monitoring and treatment of congenital heart block are all conditional in this particular guideline, given the rarity of this condition, and also large case series are not available. So in women with a prior history of neonatal lupus, recommendation is for weekly fetal echocardiogram between 16 to 26 weeks gestation. And in women with no prior history of neonatal lupus, serial echocardiograms is recommended, perhaps less frequently than weekly. With regards to in the event that there's an abnormal fetal echocardiogram, duration of dexamethasone is uncertain, and there's some controversy surrounding whether dexamethasone improves long-term survival in this group of patients. The guidelines strongly recommend against the use of dexamethasone in complete heart block without other signs of cardiac inflammation. We move on to our next antibody of interest, which is antiphospholipid antibodies. And we re-stratify these patients into patients with antiphospholipid syndrome. So these are patients with a clinical phenotype of obstetric APS or the clinical phenotype of thrombotic APS. And we have another category of patients, which are patients with APL positivity alone. And these are patients with persistent positive APL antibodies and moderate to high titers of anticardiolipin antibodies, beta-2 glycoprotein antibodies, or lupus anticoagulant positivity. If we look at patients with antiphospholipid syndrome, there are several predictors which confers a higher risk of adverse pregnancy outcome. So one of these include the antiphospholipid antibody profile. So patients who are deemed at higher risk are patients with triple APL positivity or patients with lupus anticoagulant positivity. I've illustrated earlier on that patients with coexisting lupus confers a higher risk of adverse pregnancy outcome, and this again is data taken from the PROMISE trial. In terms of clinical phenotype, there's a paper that looked at the different clinical phenotypes of antiphospholipid syndrome. So this paper compared recurrent early pregnancy loss versus ischemic placental complications versus the clinical phenotype of maternal thrombosis. And the clinical phenotype of maternal thrombosis had the least favorable neonatal outcomes with a higher rate of preterm delivery and small for gestational age babies. So therefore, thrombotic APS clinical phenotype confers the highest risk of adverse pregnancy outcome. Prior pregnancy outcome is the best predictor of the current pregnancy outcome. Last but not least, we shouldn't forget traditional cardiovascular risk factors, which also confer a higher risk of adverse pregnancy outcome in antiphospholipid syndrome pregnancies. This table summarizes the current recommendation in terms of management of obstetric APS. Pregnancy loss occurs in about a quarter of obstetric APS despite therapy. So both the ACR 2020 and the EULAR APS 2019 guidelines recommend the use of combination low-dose aspirin and prophylactic low molecular weight heparin. And this is to be continued for 6 to 12 weeks postpartum. The rationale for continuation of low molecular weight postpartum is really to reduce the risk of thrombosis during the period of increased risk of VTE or increased risk of thrombosis surrounding the postpartum period. The ACR guidelines conditionally recommends the use of hydroxychloroquine in patients with primary APS, and it recommends against the use of intravenous immunoglobulin. It recommends against the use of higher doses of low molecular weight heparin, and strongly recommend against the use of prednisolone in patients with obstetric APS. If you look at the EULAR 2019 guidelines, following standard therapy, if patients fail, other therapies could be considered. We move on to our category of patients with APL positivity. So in this group of patients, consensus is really consideration of low-dose aspirin as preeclampsia prophylaxis. The ACR 2020 guidelines conditionally recommend against the use of hydroxychloroquine or the use of low molecular weight heparin in this group of patients. At the end of the day, it is a shared decision-making in individuals, particularly with those with high APL profile. So these are patients with triple positive APL antibodies or lupus anticoagulant positivity or advanced maternal age. The management of patients with a clinical phenotype of thrombotic APS is more straightforward. So these patients are on combination therapy with low-dose aspirin and therapeutic dose low molecular weight heparin. And oftentimes, these are patients on long-term anticoagulation. So we switch them to therapeutic low molecular weight heparin as soon as pregnancy is confirmed prior to 6 weeks gestation. The only caveat is for patients who do not have regular menses, and therefore one could consider switching to prophylactic low molecular weight heparin preconceptually. Pregnancy in patients with pre-existing organ damage carries profound maternal risk. So for example, patients with pulmonary arterial hypertension is associated with a high risk of mortality of up to 20%, even with aggressive therapy. So other considerations of high-risk scenarios whereby one may counsel against pregnancy includes the presence of severe restrictive lung disease, severe chronic kidney disease, stroke in the last 6 months, and severe disease flare in the last 6 months. And this brings us to the importance of contraception. If you look across both cohorts in the States and in Asia, half of pregnancies are unplanned. And if you look at reproductive age women with rheumatic diseases, only about 8% used highly effective contraceptive methods. And more concerningly is that the use of teratogenic medications was not associated with an overall use of contraception. And there are several published cohorts looking at lupus patients, and about 60% of lupus patients reported that they never received contraceptive counseling. And we all know that it is important that we do want to avoid conception during periods of disease flares and active disease when patients are taking teratogenic medications, and also when patients have severe disease-related organ damage. Preventing pregnancy relies on the use of effective and safe contraception, and therefore I think it is important to include this in our pre-pregnancy counseling for lupus patients of reproductive age. This is a brief overview about how we categorize contraceptive methods. I'll draw your attention right up to the top. So these are highly effective contraception with a pregnancy rate of less than 1%. And in this category, we have the long-acting reversible contraception, which is the intrauterine device, and the progesterone implant. If we look at the second row, these are effective contraception, which confer a pregnancy rate of about 4 to 7% per year. And in this category, we have the IM Depo-Provera, or the depomedroxyprogesterone injection, or the pill. Contraceptive methods, for example, barrier methods and fertility-based methods, are less effective and yield pregnancy rates of about 18 to 30% per year. So this table is taken from the ACR 2020 reproductive guidelines. Contraception options are categorized based on the presence of lupus, disease activity, and also the presence of APL antibodies. If you look across the board, all women can use highly effective long-acting reversible contraception, and this is the intrauterine device or the progesterone implant. If we look at the options of contraception in the effective contraception method group, all women can actually use the progestin-only pill or the intramuscular injection of Depo-Provera or depomedroxyprogesterone acetate, except for patients with positive APL and those at high risk of osteoporosis. With regards to the combined oral contraceptive pill, this is to be avoided in those with active lupus and those with positive APL antibodies. This is an overview of a patient's journey in our combined rheumatology obstetrics clinic, which we run at the Singapore General Hospital. And this is a one-stop multidisciplinary clinic, which we run together with the obstetricians. We also work very closely with the anesthetists, neonatologists, pediatricians. We've discussed the importance of pre-pregnancy counseling and the different aspects of pre-pregnancy counseling to our patients. We've discussed monitoring in terms of pregnancy. I just wanted to add a word with regards to ultrasound fetal surveillance. So aside from the routine first trimester scan for patients with lupus and antiphospholipid syndrome, recommendation is also for second trimester scan together with Doppler, given that the umbilical and uterine artery Doppler has a good negative predictive value for placenta-associated pregnancy disorders such as preeclampsia and intrauterine growth restriction. So as we all know, lupus pregnancies are at an increased risk of developing preeclampsia. Some patients may require supplementary fetal surveillance in the third trimester, particularly for those with intrauterine growth restriction. And the last column is really general obstetrics advice, which is not to be forgotten, including managing patients' BMI, blood pressure, advice with regards to smoking, alcohol, and vaccinations. With regards to the mode of delivery, there's no indication for induction of labor or elective cesarean section in patients with quiescent lupus disease activity. So just to sum up, I think it is important as physicians who look after lupus that we ask about the intentions regarding pregnancy during clinic visits. It is important that we discuss with our patients that conception needs to be timed during periods of quiescent disease while patients are taking pregnancy-compatible medications, and therefore really underpinning the importance of pre-pregnancy counseling in our lupus patients. And last but not least, risk stratifying our patients according to their antibody profile. I'm very, very happy to take any questions.
Thank you very much, Dr. Poirier, so for the wonderful lecture on the very important theme for patients with SLE. Now you got at least 3 questions. The first question is that what contraceptives do you usually give to SLE patients?
Yeah, so I think the ACR 2020 recently published reproductive guidelines. It's a great source for counseling for all aspects for lupus patients. So if you look across the board, all patients can actually have the most effective contraceptive method, which is a long-acting reversible contraception. So that's your intrauterine device and the progestin implant. And all patients also can have the progestin only pill.
Okay, thank you. Next question. Is it possible that the child will also have SLE like the mother's is?
So we often counsel our patients that given that it's a polygenic disease, that it is not 100% inheritance. The only thing to note would be the antibody risk profiling, which I've shared earlier on. So women with anti-Ro and anti-La antibodies, these antibodies can cross the placenta, and some of these babies may develop the neonatal lupus rash. However, that generally resolves once the maternal antibodies disappear from the baby, from the child.
Thank you. Next, what is the dose of enoxaparin for prevention of obstetric APS?
So for obstetric antiphospholipid syndrome, therapy is combination therapy of low-dose aspirin and prophylactic dose low molecular weight heparin. So we generally prescribe low molecular weight heparin at the dose of 40 milligrams daily for obstetric APS, and to continue this for 6 to 12 weeks postpartum, given the increased risk of thrombosis during the postpartum period.
Thank you. Next should be a final question. For APL positive antiphospholipid antibody positive SLE patient, is progestin implant safe? Progestin implant safe?
Yeah, so if you look at the recently published ACR 2020 guidelines, I think there's less data with regards to the progestin implant with regards to some concerns. So generally, our patients will advise the other form of effective contraception, which is the intrauterine device, the Mirena.
Thank you very much. So now it's a time to close this session. Thank you very much, Dr. Poirier. So today we had a APLAR webinar for SLE. Main theme was medicine gives back to SLE patients in observing or celebrating the World Lupus Day. How about it? So I think the majority of audience should be satisfied with the content and also the lectures. So I really appreciate Dr. Natalia Chen and Dr. Elena Venegas and Professor Nantama Kasitanan and Dr. Paul Yin-Jiu for the wonderful lectures. So finally, thank you very much again for your cooperation. I'll finish or close this session.
将来我们所有的都会在这个国家临床医学研究中心下面，我们 CRDC 也好 ，CISTA 也好，还有医联体联盟也好，将来都会归属在这个大的平台下面的啊。我们下面还会建立很多的，包括我们甚至要建立学院 我们甚至要建立指控中心等等因为这都是国家的任务。
数据它积累下来以后，我们现在很多这个专家，包括年轻的大夫，都在用数据去讲他的经验，而不是单纯的讲数据。迟早会有一天，就是我觉得中国的这些经验可以传递给我们国际的同行，或者跟国际行共同来合作，来去帮助更多的病人。
Ako po si Catherine, single mom of 2 and isang PWD na po.
My name is Jan Errol. BS Entrepreneurship ang natapos ko po.
Nung nalaman ko po na may lupus po ako, hindi ko po alam kung ano yung mararamdaman ko. Kasi po hindi ko po alam yung sakit ng lupus eh. Gagaling ba ako? O talagang habang buhay na may lupus po ako?
Hindi pa po namin alam kung ano yung sakit ko po. So, tumigil po ako sa pag-aaral sa dahilan na hindi ako bumababa yung lagnat ko ng 3 to 4 mas na 40 degrees po.
Nung dalaga po ako, strong talaga ako na person. Pero mas naging stronger ako nung nagkaroon ako ng anak. Na minsan nararamdaman ko nang nangihina na ako. Pero sabi ko sa sarili ko, kailangan kong maging strong para sa mga anak.
Ginaya ko yung mga dala ng sakit ng lupus kasi nandyan po yung pamilya ko po. Sinusuportahan po nila ako. So, nandyan po sila sa tabi ko para alalayan po ko.
Ang advice ko lang po sa kagaya ko pong may lupus, maging strong tayo, faith kay God, para malabanan natin yung sakit natin. Huwag tayong papatalo sa sakit natin.
Hope ko din po bilang in the future is yung maging normal po ko na tao. Kumbaga parang hindi po masyadong nadidiscriminate. And awareness po sa lupus po, buong Pilipinas or buong mundo.
Huwag lang po tayong mawawala ng pag-asa. One day, gagaling tayo.
Very thankful po ko sa Panginoong Diyos, po sa pamilya ko, sa mga doctors po. Kasi kung wala po yung doctors at pamilya ko po, saka si Papa God, wala po ko sa inyo para mag-share ng kwento ko.
There's hope for the butterflies.